Thank you very much. I've been honored to talk on this important topic of treatment. I'm a pediatrician, infectious disease, so it's really been a journey. I remember the time, some of you, I don't know if you are born yet, since we have adolescents in here, where we used to crush the tablets, where we used to use syrups, mother would go with a bag this big, the adolescents would be taking medicine 3 to 4 times a day, and we've come a long way. So I think we have a long way to go, but we've come a long way. So we should celebrate that as well. I want us to clap for the people who are responsible for that great work. So I'm going to start out with the current guidelines. We have 3 sets of guidelines. There's the WHO guidelines, which most of us in resource-limited settings follow. Then we have the American guidelines, DHHS. Then we have the European guidelines. And they're actually the same if you look across. The drugs that are recommended, dolutegravir, tenofovir, 3-TC or FTC, that's WHO. And as you can see in the WHO column, there's only one set because obviously access is the big issue for us in resource-limited settings. But we're grateful that we have that fixed dose combination. And as I was talking with some of the adolescents, it's great that it's 1 pill once a day. We've come a long way. Now, for the American guidelines, again, for 2022, they've added bictegravir, which is dolutegravir, but a newer version. It's also just as good. TAF, which we've talked about, and FTC. And those are the other combinations that can be used, including 2 drugs, DTG and 3-TC. So American colleagues, I guess you are using those. Maybe not. Then the Europeans have 3 or 4 different options, but they're pretty much the same. So all currently recommended options for treatment-naive adolescents are daily oral ART. So what are the regimens that we recommend in individuals who are virologically suppressed? What do we want to do for those individuals who are virologically suppressed? We want to reduce the pill burden or dosing frequency. I think the pill burden of once a day is quite low, but maybe we can reduce the frequency from only once a day to once a month or once every 6 months. That would be excellent. Reduce toxicity or enhance tolerability and prevent drug-drug interactions. We want to eliminate food or fluid requirements. We say take this 30 minutes before you eat or 1 hour after you eat. We want to have to avoid that. And then obviously what we've talked about already, switch to long-acting injectable regimens to relieve the pill fatigue or decrease potential stigma or disclosure concerns associated with taking daily medications. I think even as an adolescent, if every time they keep asking you, what are you taking, what are you taking? Especially in our populations where I come from, Uganda, many of the adolescents are in boarding schools. And so you have this pill, your friends are, why are you always taking medicine? You may say I have malaria for a week, but malaria should go away. Okay, and then we have clinical data for long-acting injectable cabotegravir with rilpivirine in adolescents with HIV. This is exciting. We looked at it for prevention. That's the right side of the slide, so I won't repeat that. But on the left side of the slide, we see that that combination can be used not only for prevention, but for treatment. And Atlas, FLAIR, and Atlas 2M are just names of studies that were done in adults looking at long-acting injectable for treatment using 2 drugs, and they were actually showed efficacy. Now, these data for adolescents is called the MOCA study, Impact 2017, and they had the first cohort where they're really looking at pharmacokinetics with the drugs in adolescents. Levels, were the drug levels the same as it showed in adults? Because adults had very good levels. So these studies showed that in the phase 1 and 2 study in participants aged 12 to 18 years, the drugs were safe, they were acceptable, tolerable, and the PK of long-acting cabotegravir, as well as long-acting rilpivirine, dosed every 4 weeks while containing background ART as well, were actually similar to what was seen in adults. So that was good news at week 16. from the interim analysis is what I've just said. The data was comparable. Now the follow-up, which is cohort 2 of that MOCA or Impact 2017, is further looking at the safety and tolerability of this regimen, but dosed every 8 weeks, which is every 2 months. Once a month is good, but once in 2 months would be better. Someone told me once in 3 months would be best, but we're still at once in 2 months. And that study is actually ongoing, and even at our site, we're still doing 2017 with good results so far. So this is just to show you the graphs of the pharmacokinetic data. I've said it's true that the adult and the ped data were similar, but I wanted you to see it for yourself. If you look at the graphs, is there a laser? Yes. The one on the left, oh, seems I'm not very good. Oh, it won't work. Okay. So the one on the left, which has the green color on the bar on the line graph, the first side is vertical axis is the plasma cabotegravir, horizontal axis is time. So the green one is the MOCA study, or the Impact 2017, showing the levels were adequate, similar to what was shown in FLAIR and ATLAS, which were the adult studies. That's on cabotegravir long-acting injectable. If you look at the graph on the right, which is again vertical axis, is plasma levels of rilpivirine, long-acting, again through an injection. The red line is the MOCA study, and the other black lines are FLAIR and ATLAS. And as you can see, even from the back of the room, they're actually similar. So IM administration of CAB-LA and rilpivirine-LA in adolescents achieved target concentrations comparable to those reported in adults. That is great news. So again, when we look at Impact 2017, the overall results of the qualitative analysis, the overall perception of injections was favorable, and we've also heard from the previous youth who shared. The quality of life was similar before and after initiation of long-acting injectables. 90% reported wanting to receive long-acting ART after the study ended. Obviously, there are advantages and concerns. The advantages of long-acting injectable versus pills is not having to take pills is an advantage. You don't have to remember, did I take it today? Did I not take it today? Avoiding the stress of monitoring adolescent daily medication taking. Adolescents are supposedly able to take medication by themselves, but sometimes they do need help. Not having to worry about hiding pills from peers, we've talked about. The concerns are that the ability to maintain a routine injection schedule when busy with school, extracurricular activities, and work, particularly for those planning to move to college. Where are we going to go if you're college every month? I'm going off to get my injections, since it may not be at the college itself where you receive your care. Overall, the first adolescent to access long-acting injectable through the MOCA study and their parents found the formulation to be acceptable. Great news. Now, products for potential interest for the future, we can look at fixed dose combination, ALD. That combination is recommended for most children as first-line therapy. And then there's darunavir, also recommended treatment for children who have resistance to DTG in terms of second line. Then there's TAF, XTC, and DTG for first line and second line. DTG is recommended actually for first and second line because of the high resistance barrier. And then long-acting cabotegravir for treatment of postnatal prophylaxis only right now. That's what they're thinking about in mothers whose infants were exposed to HIV. And then islatravir is postnatal prophylaxis continuation with the newer technology for drugs for treatment. Islatravir was in development, but it's on hold right now. It was on the treatment is prophylaxis for using islatravir is on hold. It's an oral prophylaxis, long-acting, and it's had some issues related to the white cell count and the toxicity that was noted. So it was put on hold, but I'm sure it's going to continue in other areas. Then there's lenacapavir, which we've already heard about, oral multi-month subcutaneous injection. This is given every 6 months. There's promise for it as prophylaxis. The studies are ongoing, but there's also promise for treatment. We've talked about the broadly neutralizing antibody, multi-month subcutaneous injection, either with antiretrovirals or as a way to prevent after someone's suppressed, to keep them suppressed for a longer period of time. Again, still in research. Then the microarray patches. This would be a great idea. Instead of injections, instead of taking tablets, then you could have a patch that you could wear as a form of treatment. Again, we said watch this list because they're not yet readily available for treatment. Now, the fourth conference on antiretroviral optimization, long-acting cabotegravir for PrEP, we've already talked about that. That's given every 8 weeks, but it's actually they're looking at giving it every 3 months in clinical studies to see whether it will actually be beneficial, especially since many young girls also get injectable Depo-Provera for contraception. Okay, my time is nearly up, so I will move on faster. There's adults and HIV treatment with 2 drugs, which we've already talked about. It's effective and well tolerated in the Gemini 1 and 2 studies. DTG and 3TC combination demonstrated rapid and durable efficacy in treatment at naive adults through 144 weeks. So that's the adult data, but we also have the pediatric data using 2 drugs. 2 drugs are good because, again, you're reducing the toxicity and drug-drug interaction. That's the aim of trying to move to 2 drugs, because people may say, we have 3 drugs, it's 1 pill once a day, it's working, why are we struggling? Okay, and this is the dance study. I won't spend much time because I've been told my time is nearly up. It's already been presented. Broadly neutralizing antibodies. These are well explained by our previous speaker, and they have been studies that are ongoing. Nothing's been proven, but we do know that there are different cocktails that are going to be used. And again, because of time, you can see them on the list. There are different ones that have been used. The proof of concept has shown that brugelonizing antibodies, VCR01-LS and 1074, maintain viral suppression in about 40% adolescent children in this trial, much higher than expected of 30%, but again, to be higher than 40% to be something to use. So those are the pipeline that are up soon. And inhibitors, another class representing an option for targeting HIV. And we're trying to see if with more classes, hopefully the better in the prevention of HIV. The maturators, when the proteins by the virus, they're able to cleave into smaller proteins, pieces. The maturation inhibitors prevent cleaving into protein pieces. A new class, and they will be when they are tried in the human. So we have had an evolution of ARV and future pipeline. As I said long ago, with drugs that were syrups and other day. So the goals of ARV treatment toxicity and simplify the evolution of these, the backbone. Then we moved into 3 agents. Now we're moving into 1 long-acting. And the key drug development, first ARV was AZ, 1987. I don't know if you were born yet, but we come a long way. Then we had the first improved the treatment effectiveness. Then we moved to and a fixed dose combination. Now, as we've said, we're moving into dosing frequency 2 to 3, new mechanisms of action, and long-acting injection even up to drugs that are governed not 2 months, but even every 6 months. So maybe we'll get to the point where we have the patch, you're diagnosed, you're infected, you get your patch, and maybe it's replaced every 5 years, maybe every 10 years, maybe it's never replaced, and you just have your patch. And there are obviously many other areas that people are looking into, things that will be effective and help, maturation inhibitors, bodily neutralizing antibodies. I think we have a long way to go, but we have come a long way. Thank you very much for your time.